Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in the field of Hemato Oncology. First, we will be discussing articles in New England Journal of Medicine. Risk of second tumors and T-cell lymphoma after CAR T-cell therapy. Background. The risk of second tumors after chimeric antigen receptor, CAR, T-cell therapy, especially the risk of T-cell neoplasms related to viral vector integration, is an emerging concern. Methods. We reviewed our clinical experience with adoptive cellular CAR T-cell therapy at our institution since 2016, and ascertained the occurrence of second tumors. In one case of secondary T-cell lymphoma, a broad array of molecular, genetic, and cellular techniques were used to interrogate the tumor, the CAR T-cells, and the normal hematopoietic cells in the patient. Results. A total of 724 patients who had received T-cell therapies at our center were included in the study. A lethal T-cell lymphoma was identified in a OFF patient who had received axicabtagene ciloleucel therapy for diffuse large B-cell lymphoma, and both lymphomas were deeply profiled. Each lymphoma had molecularly distinct immunophenotypes and genomic profiles, but both were positive for Epstein-Barr virus, and were associated with A.I.O and TET, 2 mutant clonal hematopoiesis. No evidence of oncogenic retroviral integration was found with the use of multiple techniques. Conclusions. Our results highlight the rarity of second tumors, and provide a framework for defining clonal relationships and viral vector monitoring. Next, we will be discussing articles from Journal of Clinical Oncology updated analysis of comparative toxicity of proton and photon radiation for prostate cancer. Purpose. Previous comparative effectiveness studies have not demonstrated a benefit of proton beam therapy, PBT, compared with intensity modulated radiation therapy, IMRT, for prostate cancer. An updated comparison of GI and genitourinary, GU, toxicity is needed. Methods. We investigated the SEER Medicare-linked database, identifying patients with localized prostate cancer, diagnosed from 2010 to 2017. Procedure and diagnosis codes indicative of treatment-related toxicity were identified. As a sensitivity analysis, we also identified toxicity based only on procedure codes. Patients who underwent IMRT and PBT were matched 2-to-1 on the basis of clinical and socio-demographic characteristics. We then compared GI and GU toxicity at 6, 12, and 24 months after treatment. Results. The final sample included 772 PBT patients, matched to 1,544 IMRT patients. The frequency of GI toxicity for IMRT versus PBT was 3.5% versus 2.5% at 6 months. P equals 0.18, 9.5% versus 10.2% at 12 months. P equals 0.18 and 20.5% versus 23.4% at 24 months. P equals 0.11. The frequency of only procedure codes indicative of GI toxicity for IMRT versus PBT was too low to be reported, and not significantly different. The frequency of GU toxicity for IMRT versus PBT was 6.8% versus 5.7%. P equals 0.30, 14.3% versus 12.2%. P equals 0.13 and 28.2% versus 25.8%. P equals 0.21 at 6, 12, and 24 months respectively. When looking only at procedure codes, the frequency of GU toxicity for IMRT was 1.0% at 6 months, whereas it was too infrequent to report for PBT, P equals 0.64. GU toxicity for IMRT versus PBT was 3.3% versus 2.1%, p equals 0.10, and 8.7% versus 6.7%, p equals 0.10, at 12 and 24 months, respectively. Conclusion. In this observational study, there were no statistically significant differences between PBT and IMRT in terms of GI or GU toxicity. Next, we will be discussing articles in the field of gastroenterology. Next, we will be discussing articles from clinical gastroenterology. Association between Vonoprazan and the risk of gastric cancer after Helicobacter pylori eradication. Background and aims. Potassium competitive acid blockers, PKBs, have been increasingly used to treat upper gastrointestinal disorders, replacing proton pump inhibitors, PPIs. Whereas PPIs are associated with an increased risk of gastric cancer, GC, after Helicobacter pylori, HP, eradication, it is uncertain whether PKBs carry the same risk. Methods. Using a population-based claims database in Japan, we identified patients who were prescribed a clarithromycin-based first regimen of HP eradication between 2015 and 2018. Patients who failed this regimen and those diagnosed with GC before or within 1 year after HP eradication were excluded. We compared GC incidence between PKB users and histamine type 2 receptor antagonist, H2-Ra, users, matching them on the basis of propensity scores, calculated with considerations for age, sex, smoking, alcohol consumption, comorbidities, and co-administered medications. PKBs included only Vonoprazan in this study. Results. Among 54,055 patients, 568, 1.05%, developed GC during the follow-up period, mean 3.65 years. The cumulative incidence of GC was 1.64% at 3 years, 2.02% at 4 years, and 2.36% at 5 years in PKB users, and 0.71% at 3 years, 1.04% at 4 years, and 1.22% at 5 years in H2-Ra users. The use of PKBs was associated with a higher GC risk. Matched hazard ratio, 1.92, 95% confidence interval, 1.13 to 3.25, p equals 0.016. Longer PCAB use and high-dose PCAB use were significantly associated with higher incidence of GC. Sensitivity analyses showed the risk of GC incidence among PKB users was comparable with that of PPI users. Conclusions. The use of PKBs was associated with an increased risk of GC among HP-eradicated patients, with duration/dose response effects. Impact of treatment response on risk of serious infections in patients with Crohn's disease, secondary analysis of the Pyramid Registry. Background and aims. Traditional risk factors for serious infections with advanced therapies in patients with Crohn's disease, CD, have been assessed at baseline before starting therapy. We evaluated the impact of treatment response on the risk of serious infections in adalimumab-treated patients with CD through secondary analysis of the Pyramid Registry, NCT 005-24537. Methods. We included patients with CD who initiated adalimumab and classified them as treatment responders, achieved steroid-free clinical remission based on patient-reported outcomes, versus non-responders, not in steroid-free clinical remission, at 6 months after treatment initiation, landmark. We compared the risk of serious infections between responders versus non-responders between 6 and 36 months after treatment initiation through stabilized inverse probability of treatment weighting Cox proportional hazards model. Results. Of 1,515 adalimumab-treated patients, 763, 50.4%, were classified as responders at 6 months, 37 plus or minus 13 years, 56% female. Disease duration, 9.5 plus or minus 8.5 years. Compared with non-responders, responders were less likely to have moderate to severe symptoms, 55.6% versus 33%, or require steroids, 45.5% versus 17.3%, or opiates, 6.6% versus 1.3% at baseline, without any differences in disease location, perianal disease, and prior CD complications. During follow-up evaluation, using stabilized inverse probability of treatment weighting, responders were 34% less likely to experience serious infections compared with non-responders. Hazard ratio, 0.66, 95% CI, 0.46 to 0.96. Risk of gastrointestinal and extraintestinal infections was lower in responders versus non-responders. Conclusions. Patients with CD who respond to adalimumab have a lower risk of developing serious infections compared with non-responders. These findings underscore that initiation of advanced therapy for CD may lower the risk of serious infections through effective disease control and avoidance of corticosteroids. Next, we will be discussing articles in the field of infectious diseases from Journal of American Medical Association. Continuous versus intermittent beta-Lactam antibiotic infusions in critically ill patients with sepsis. Importance: whether beta-Lactam antibiotics administered by continuous compared with intermittent infusion reduces the risk of death in patients with sepsis is uncertain. Objective: to evaluate whether continuous versus intermittent infusion of a beta-Lactam antibiotic, piperacillin tazobactam or meropenem, results in decreased all-cause mortality at 90 days in critically ill patients with sepsis. Design, setting, and participants. An international, open-label, randomized clinical trial conducted in 104 intensive care units, ICUs, in Australia, Belgium, France, Malaysia, New Zealand, Sweden, and the United Kingdom. Recruitment occurred from March 26, 2018, to January 11, 2023, with follow-up completed on April 12, 2023. Participants were critically ill adults, greater than or equal to 18 years, treated with piperacillin tazobactam or meropenem for sepsis. Intervention-eligible patients were randomized to receive an equivalent 24-hour dose of a beta-Lactam antibiotic by either continuous, N equals 3,498, or intermittent, N equals 3,533, infusion for a clinician-determined duration of treatment, or until ICU discharge, whichever occurred first. Main outcomes and measures. The primary outcome was all-cause mortality within 90 days after randomization. Secondary outcomes were clinical cure up to 14 days after randomization, new acquisition, colonization, or infection with a multi-resistant Crohn's organism or Clostridioides difficile infection up to 14 days after randomization, ICU mortality, and in-hospital mortality. Results among 7,202 randomized participants, 7,031. Mean, SD, age, 59, 16 years, 2,423 women, 35%, met consent requirements for inclusion in the primary analysis, 97.6%. Within 90 days, 864 of 3,474 patients, 24.9%, assigned to receive continuous infusion, had died compared with 939 of 3,507. 26.8%, assigned intermittent infusion, absolute difference, minus 1.9%, 95% CI, minus 4.9% to 1.1%. Odds ratio, 0.91, 95% CI, 0.81 to 1.01. P equals 0.08. Clinical cure was higher in the continuous versus intermittent infusion group, 1933,467, 55.7%, and 1744, 3,491, 50.0%, respectively. Absolute difference, 5.7%, 95% CI, 2.4% to 9.1%. Other secondary outcomes were not statistically different. Conclusions and relevance. The observed difference in 90-day mortality between continuous versus intermittent infusions of beta-Lactam antibiotics did not meet statistical significance in the primary analysis. However, the confidence interval around the effect estimate, includes the possibility of both no important effect and a clinically important benefit in the use of continuous infusions in this group of patients. Next, we will be discussing articles from Clinical Infectious Diseases. Development of patient safety measures to identify inappropriate diagnosis of common infections. Background. Inappropriate diagnosis of infections results in antibiotic overuse and may delay diagnosis of underlying conditions. Here we describe the development and characteristics of two safety measures of inappropriate diagnosis of urinary tract infection, UTI, and community-acquired pneumonia, CAP, the most common inpatient infections on general medicine services. Methods. Measures were developed from guidelines and literature and adapted, based on data from patients hospitalized with ICE, UTI and CAP in 49 Michigan hospitals and feedback from end users, a technical expert panel, TEP, and a patient focus group. Each measure was assessed for reliability, validity, feasibility, and usability. Results. Two measures, now endorsed by the National Quality Forum, NQF, were developed. Measure reliability, derived from 24,483 patients, was excellent, 0.90 for UTI, 0.91 for CAP. Both measures had strong validity demonstrated through A. Face validity by hospital users, the TEPS, and patient focus group. B. Implicit case review, 0.72 for UTI, 0.72 for CAP, and C. Rare case misclassification, 4% for UTI, 0% for CAP, due to data errors, less than 2% for UTI, 6.3% for CAP. Measure implementation through hospital peer comparison in Michigan hospitals, 2017 to 2020, demonstrated significant decreases in inappropriate diagnosis of UTI and CAP, 37% and 32%, respectively, p less than 0.001, supporting usability. Conclusions. We developed highly reliable, valid, and usable measures of inappropriate diagnosis of UTI and CAP for hospitalized patients. Hospitals seeking to improve diagnostic safety, antibiotic use, and patient care should consider using these measures to reduce inappropriate diagnosis of CAP and UTI. Next, we will be discussing articles in the field of rheumatology. Next, we will be discussing articles from Journal of Clinical Rheumatology. Comparative effectiveness of tofacitinib and adalimumab in axial spondyloarthritis, a real-world clinical context multicenter study. Introduction. Tofacitinib, an oral Janus kinase inhibitor, is a putative choice in the treatment of axial spondyloarthritis, AX-SPA. The objective of this study was to compare the effectiveness and tolerability of tofacitinib with adalimumab in AX-SPA in a real-world clinical setting. Methods. In this multicentric medical records review study, adult patients with active AX-SPA treated with either tofacitinib 5 mg twice daily or adalimumab 40 mg subcutaneously fortnightly were recruited. Effectiveness was measured with ankylosing spondylitis disease activity score, ASDAS, and Bath ankylosing spondylitis disease activity index, BASDAI. Drug cost analysis was calculated with incremental cost-effectiveness ratio, ICHR drug. Results. Among the 266 patients, 135 were treated with tofacitinib and 131 with adalimumab. Follow-up. 6.5 plus or minus 1.6 months. Mean improvement of BASDAI, 3.39 plus or minus 0.09 versus 3.14 plus or minus 1.16, respectively, and that of ASDAS, 1.78 plus or minus 0.68 versus 2.07 plus or minus 2.08, respectively, were comparable between the adalimumab and tofacitinib groups. A higher proportion of patients achieved BASDAI 50 response in the second, 49.5% versus 31.6%, and fourth month, 83.9% versus 62.8%, and ASDAS low disease activity in the fourth month, 71.6% versus 47.9% in the adalimumab group. All disease activity measurements were similar by the 6th month in both groups. A higher proportion of patients in the tofacitinib group than in the adalimumab group required change in therapy, 14.8% versus 7.6% respectively. Each hair drug for adalimumab compares with tofacitinib was US $188.80 per patient in the adalimumab group for each person month, with BOSTI less than 4. Conclusions. Tofacitinib showed comparable effectiveness with adalimumab in patients with AXPA at the 6th month, despite lesser response in the initial months, with favorable each hair drug. Next, we will be discussing articles from Arthritis and Rheumatology, Hydroxychloroquine in Lupus Pregnancy, and Risk of Preeclampsia. Objective. Systemic lupus erythematosus, SLE, disproportionately affects women during childbearing years, and hydroxychloroquine, HCQ, is the standard first-line treatment. Preeclampsia complicates up to 1/3 of pregnancies in lupus patients. Although reports vary by parity and multifetal gestation, we investigated whether taking HCQ early in pregnancy may reduce the risk of preeclampsia. Methods. We studied 1,068 live birth singleton pregnancies among 1,020 privately insured patients with SLE, 2007 to 2016. HCQ treatment was defined as 3 months preconception through the first trimester, and prescription fills were a proxy for taking HCQ. Modified Poisson regression estimated risk ratios, RRs, and 95% confidence intervals, Cs, stratified by parity. Propensity scores accounted for confounders, and stratified analyses examined effect modification. Results. Approximately 15% of pregnant patients were diagnosed with preeclampsia. In 52% of pregnancies, patients had 1 or more HCQ fills. Pregnant patients exposed to HCQ had more comorbidities, SLE activity, and azathioprine treatment. We found no evidence of a statistical association between HCQ and preeclampsia among nulliparous. RR 1.26, 95% CI 0.82 to 1.93, and multiparous pregnancies, RR 1.20, 95%, CI 0.80 to 1.70. Additional controls for confounding decreased the RRs toward the nulliparous pregnancy. Propensity score adjusted, PS adjective, RR 1.09, 95%, CI 0.68 to 1.76, multiparous pregnancy. CS adjective, RR 1.01, 95% CI 0.66 to 1.53. Conclusion. Using a large insurance-based database, we did not observe a decreased risk of preeclampsia associated with HCQ treatment in pregnancy, although we cannot rule out residual and unmeasured confounding and misclassification. Further studies leveraging large population-based data and prospective collection could characterize how HCQ influences preeclampsia risk in pregnant patients with SLE and among persons at greater risk of hypertensive disorders of pregnancy. Next, we will be discussing articles in the field of cardiology. From Annals of Internal Medicine. The effect of heat exposure on myocardial blood flow and cardiovascular function. Background. Heat extremes are associated with greater risk for cardiovascular death. The pathophysiologic mechanisms mediating this association are unknown. Objective. To quantify the myocardial blood flow, MBF, requirements of heat exposure. Design. Experimental study. ClinicalTrials.gov, NCT 045499744 setting. Laboratory-based. Participants. 61 participants, comprising 20 healthy young adults, mean age, 28 years, 21 healthy older adults, mean age, 67 years, and 20 older adults with coronary artery disease, CAD, mean age, all 70 years. Intervention. Participants were heated until their core temperature increased 1.5 degrees Celsius. MBF was measured before heat exposure and at every increase of 0.5 degrees Celsius in core temperature. Measurements. The primary outcome was MBF measured by positron emission tomography computed tomography. Secondary outcomes included heart rate, blood pressure, and body weight change. Results. At a core temperature increase of 1.5 degrees Celsius, MBF increased in healthy young adults, change, 0.8 milliliters per minute/g, 95% CI, 0.5 to 1.0 milliliters per minute/g, healthy older adults, change, 0.7 milliliters per minute/g, CI, 0.5 to 0.9 milliliters per minute/g, and older adults with CAD, change, 0.6 milliliters per minute/g, CI, 0.3 to 0.8 milliliters per minute/g. This represented a 2.08-fold, CI, 1.75 to 2.41-fold, 1.79-fold, CI, 1.59 to 1.98-fold, and 1.64-fold, CI, 1.41 to 1.87-fold, change, respectively, from pre-exposure values. Imaging evidence of asymptomatic heat-induced myocardial ischemia was seen in 7 adults, with CAD, 35%, in post-hoc analyses. Limitations. In this laboratory-based study, heating was limited to about 100 minutes, and participants were restricted in movement and fluid intake. Participants refrained from strenuous exercise and smoking, stopped alcohol and caffeine intake, and withheld beta blockers, calcium channel blockers, and nitroglycerin before heating. Conclusion. Heat exposure that increases core temperature by 1.5 degrees Celsius nearly doubles MBF. Changes in MBF did not differ by age or presence of CAD, but some older adults with CAD may experience asymptomatic myocardial ischemia. From British Medical Journal. Antiplatelet therapy after coronary artery bypass surgery, 5-year follow-up of randomized DCAB trial. Abstract. Objective. To assess the effect of different antiplatelet strategies on clinical outcomes after coronary artery bypass grafting. Design 5-year follow-up of randomized different antiplatelet therapy strategy after coronary artery bypass grafting, DCAB trial. Setting 6 tertiary hospitals in China. Enrollment between July 2014 and November 2015. Completion of 5-year follow-up from August 2019 to June 2021. Participants 500 patients aged 18 to 80 years, including 91, 18.2%, women, who had elective coronary artery bypass grafting surgery and completed the DCAB trial. Interventions patients were randomized 1:1:1 to ticagrelor 90 mg twice daily, plus aspirin 100 mg once daily, dual antiplatelet therapy, N equals 168, ticagrelor monotherapy 90 mg twice daily, N equals 166, or aspirin monotherapy 100 mg once daily, N equals 166, for 1 year after surgery. After the first year, antiplatelet therapy was prescribed according to standard of care by treating physicians. Main outcome measures. The primary outcome was major adverse cardiovascular events, a composite of all-cause death, myocardial infarction, stroke, and coronary revascularization, analyzed using the intention to treat principle. Time to event analysis was used to compare the risk between treatment groups. Multiple post-hoc sensitivity analyses examined the robustness of the findings. Results follow-up at 5 years for major adverse cardiovascular events was completed for 477, 95.4% of 500 patients. 148 patients had major adverse cardiovascular events, including 39 in the dual antiplatelet therapy group, 54 in the ticagrelor monotherapy group, and 55 in the aspirin monotherapy group. Risk of major adverse cardiovascular events at 5 years was significantly lower with dual antiplatelet therapy versus aspirin monotherapy, 22.6%, v 29.9%, hazard ratio 0.65, 95% confidence interval 0.43 to 0.99, p equals 0.04, and versus ticagrelor monotherapy, 22.6%, v 32.9%, 0.66, 0.44 to 1.00. P equals 0.05. Results were consistent in all sensitivity analyses. Conclusions: treatment with ticagrelor dual antiplatelet therapy for 1 year after surgery reduced that risk of major adverse cardiovascular events at 5 years after coronary artery bypass grafting, compared with aspirin monotherapy or ticagrelor monotherapy. Next, we will be discussing articles from Circulation. Effect of empagliflozin on heart failure outcomes after acute myocardial infarction, insights from the IMPACT-ME trial. Background: empagliflozin reduces the risk of heart failure, HF, events in patients with type 2 diabetes, at high cardiovascular risk, chronic kidney disease, or prevalent HF, irrespective of ejection fraction, whereas the IMPACT-ME trial, effect of empagliflozin on hospitalization for heart failure and mortality in patients with acute myocardial infarction, showed that empagliflozin does not reduce the risk of the composite of hospitalization for HF and all-cause death. The effect of empagliflozin on first and recurrent HF events after myocardial infarction is unknown. Methods: IMPACT-ME was a double-blind, randomized, placebo-controlled, event-driven trial that randomized 6,522 patients hospitalized for acute myocardial infarction at risk for HF on the basis of CUN, newly developed left ventricular ejection fraction of less than 45%, or signs or symptoms of congestion, to receive empagliflozin 10 mg daily or placebo within 14 days of admission. In pre-specified secondary analyses, treatment groups were analyzed for HF outcomes. Results: over a median follow-up of 17.9 months, the risk for first HF hospitalization and total HF hospitalizations was significantly lower in the empagliflozin compared with the placebo group, 118, 3.6%, versus 153, 4.7%, patients with events, hazard ratio, 0.77, 95% CI, 0.60, 0.98. P equals 0.031 for first HF hospitalization, 148 versus 207 events, rate ratio 0.67, 95% CI 0.51, 0.89. P equals 0.006 for total HF hospitalizations. Subgroup analysis showed consistency of empagliflozin benefit across clinically relevant patient subgroups for first and total HF hospitalizations. The need for new use of diuretics, renin-angiotensin modulators, or mineralocorticoid receptor antagonists after discharge was less in patients randomized to empagliflozin versus placebo, all p less than 0.05. Conclusions: empagliflozin reduced the risk of HF in patients with left ventricular dysfunction or congestion after acute myocardial infarction. Next, we will be discussing articles. American College of Cardiology. Evaluate renal function with semaglutide once weekly. Contribution to literature. The FLOW trial showed that among patients with CKD and DM2, once weekly subcutaneous semaglutide was superior to placebo in improving renal and CV outcomes over a median follow-up of 3.4 years. Description: the goal of the trial was to compare the safety and efficacy of semaglutide among patients with chronic kidney disease, CKD, and type 2 diabetes mellitus, DM2. Study design: patients were randomized in 1-to-1 fashion to once-weekly subcutaneous semaglutide, N equals 1,767, or matching placebo, N equals 1,766. An 8-week dose escalation regimen was used, with dose escalation, as long as unacceptable side effects did not occur, from 0.25 mg per week for 4 weeks and half a milligram per week for another 4 weeks, followed by a maintenance dose of 1.0 mg per week throughout the remainder of the treatment period. Total screened, 5,581. Total randomized participants, 3,533. Median duration of follow-up, 3.4 years. Median patient age, 66.6 years. Percentage female, 30.3%. Inclusion criteria: DM2, with glycated hemoglobin, HbA1c, less than or equal to 10%. High-risk CKD, estimated glomerular filtration rate. IgFR, 25 to 75 milliliters per minute / 1.73 square meters, with a urinary albumin to creatinine ratio of greater than 300 and less than 5,000, if the IgFR was greater than or equal to 50 milliliter per minute / 1.73 square meters, or a urinary albumin to creatinine ratio of greater than 100 and less than 5,000, if the IgFR was 25 to less than 50, receiving a stable maximal labeled dose, or the maximal dose, without unacceptable side effects, of renin-angiotensin system inhibitors, angiotensin-converting enzyme inhibitor, ACE/angiotensin receptor blocker, ARB, other salient features/characteristics. White race, 65.8%, Asian, 23.9%. Median body weight, 89.6 kilograms. Median body mass index, 32 kilograms/m2. Mean HbA1c, 7.8%. Mean blood pressure, BP, 138.6/76.4 millimeters Hg. Baseline mean IgFR, 47 milliliters per minute / 1.73 square meters. Previous myocardial infarction, MI/stroke, 22.9%. Baseline medications: ARCHA, 35.1%. ARB, 60.2%. Diuretic, 50.4%. Lipid-lowering therapy, 80.2%. Sodium glucose cotransporter 2, SGLT2, inhibitor, 15.6%. Principal findings: the trial was terminated early due to efficacy. The primary endpoint, major kidney disease events, a composite of onset of kidney failure, initiation of long-term dialysis, kidney transplantation, or a reduction in the IgFR to less than 15 milliliters per minute / 1.73 square meters, sustained for greater than or equal to 28 days. A sustained, for greater than or equal to 28 days, greater than or equal to 50% reduction in IgFR from baseline, or death from kidney-related or cardiovascular, CV, cause, for semaglutide versus placebo, was 18.7% versus 23.2%. Hazard ratio, HR, 0.76, 95% confidence interval, CI, 0.66 to 0.88, P equals 0.0003. Next, we will be discussing articles in the field of endocrinology. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Cushing's syndrome is associated with gut microbial dysbiosis and cortisol-degrading bacteria. Context: Cushing's syndrome, CS, is a severe endocrine disease characterized by excessive secretion of cortisol, with multiple metabolic disorders. While gut microbial dysbiosis plays a vital role in metabolic disorders, the role of gut microbiota in CS remains unclear. Objective: the objective of this work is to examine the alteration of gut microbiota in patients with CS. Methods: we performed shotgun metagenomic sequencing of fecal samples from 78 patients with CS and 78 healthy controls matched for age and body mass index. Furthermore, we verify the cortisol degradation capacity of Ruminococcus novis in vitro and identify the potential metabolite by LCMC/Ms. Results: we observed significant differences in microbial composition between CS and controls in both sexes, with CS showing reduced Bacteroidetes, Bacteroides vulgaris, and elevated Firmicutes, Erysipola _bacterium _6_1_45, and Proteobacteria, Enterobacter cloaca. Despite distinct causes of hypercortisolism in ACTH-dependent and ACTH-independent CS, we found no significant differences in metabolic profiles or gut microbiota between the two subgroups. Furthermore, we identified a group of gut species, including R. novis, that were positively correlated with cortisol levels in CS. These bacteria were found to harbor cortisol-degrading DSAB genes, and were consistently enriched in CS. Moreover, we demonstrated the efficient capacity of R. navis to degrade cortisol to 11 oxygenated androgens in vitro. Conclusion. This study provides evidence of gut microbial dysbiosis in patients with CS and identifies a group of Cs-enriched bacteria capable of degrading cortisol. These findings highlight the potential role of gut microbiota in regulating host steroid hormone levels and consequently host. Next, we will be discussing articles in the field of neurology. From Lancet. Tenecteplase versus standard of care for minor ischemic stroke with proven occlusion, Tempo 2. Background. Individuals with minor ischemic stroke and intracranial occlusion are at increased risk of poor outcomes. Intravenous thrombolysis with tenecteplase might improve outcomes in this population. We aimed to test the superiority of intravenous tenecteplase over non-thrombolytic standard of care in patients with minor ischemic stroke and intracranial occlusion or focal perfusion abnormality. Methods. In this multi-center, prospective, parallel group, open label with blinded outcome assessment, randomized controlled trial, adult patients, aged greater than or equal to 18 years, were included at 48 hospitals in Australia, Austria, Brazil, Canada, Finland, Ireland, New Zealand, Singapore, Spain, and the UK. Eligible patients with minor acute ischemic stroke, National Institutes of Health Stroke Scale score 0 to 5, and intracranial occlusion or focal perfusion abnormality were enrolled within 12 hours from stroke onset. Participants were randomly assigned, 1-to-1, using a minimal sufficient balance algorithm to intravenous tenecteplase, 0 middle.25 mg/kg, or non-thrombolytic standard of care, control. Primary outcome was a return to baseline functioning on pre-morbid modified Rankin scale score in the intention to treat ITT population, all patients randomly assigned to a treatment group and who did not withdraw consent to participate, assessed at 90 days. Safety outcomes were reported in the ITT population and included symptomatic intracranial hemorrhage and death. This trial is registered with clinicaltrials.gov. NCT 02398656, and is closed to accrual. Findings. The trial was stopped early for futility. Between April 27, 2015, and Jan 19, 2024, 886 patients were enrolled, 369, 42%, were female, and 517, 58%, were male. 454, 51%, were assigned to control, and 432, 49%, to intravenous tenecteplase. The primary outcome occurred in 338, 75%, of 452 patients in the control group, and 309, 72%, of 432 in the tenecteplase group. Risk ratio, RR, 0 middle.96, 95% CI 0 middle.88, to 1 middle.04, P equals 0 middle.29. More patients died in the tenecteplase group, 20 deaths, 5%, than in the control group, 5 deaths, 1%. Adjusted hazard ratio, 3 middle.8, 95%, CI, 1 middle.4, to 10 middle.2. P equals 0 middle.0085. There were 8, 2%, symptomatic intracranial hemorrhages in the tenecteplase group versus 2, less than 1%, in the control group. RR 4 middle.2, 95% CI 0 middle.9, to 19 middle.7, P equals 0 middle.059. Interpretation. There was no benefit and possible harm from treatment with intravenous tenecteplase. Patients with minor stroke and intracranial occlusion should not be routinely treated with intravenous thrombolysis. Next, we will be discussing articles from neurology. Herpes simplex virus encephalitis in patients with autoimmune conditions or exposure to immunomodulatory medications. Background and objectives. Among infectious etiologies of encephalitis, herpes simplex virus type 1, HSV1, is most common, accounting for 15% to 40% of adult encephalitis diagnoses. We aim to investigate the association between immune status and HSV encephalitis, HSVE. Using a U.S. Medicaid database of 75.6 million persons, we evaluated the association between HSVE and autoimmune conditions, exposure to immunosuppressive and immunomodulatory medications, and other medical comorbidities. Methods. We used the U.S. Medicaid Analytic E-extract data between 2007 and 2010 from the 29 most populated American states. We first examined the crude incidence of HSVE in the population. We then age and sex matched adult cases of HSVE with a sufficient enrollment period, 12 months before HSVE diagnosis, to a larger control population without HSVE. In a case control analysis, we examined the MAT association between HSVE and exposure to both autoimmune disease and immunosuppressive/immunomodulatory medications. Analyses were conducted with conditional logistic regression, progressively adjusting for socio-demographic factors, Charlson Comorbidity Index, and non-autoimmune comorbidities. Results. Incidence of HSVE was 3.01 per 105 person-years among adults. A total of 951 HSVE cases and 95,100 age and sex-matched controls were compared. The HSVE population had higher rates of medical comorbidities than the control population. The association of HSVE and autoimmune conditions was strong. Adjusted odds ratio, OR, 2.6. 95%, CI, 2.2 to 3.2. The association of HSVE and immunomodulating medications had an OR of 2.2, CI 1.9 to 2.6, also after covariate adjustment. When both exposures were included in regression models, the associations remained robust, OR 2.3, CI 1.9 to 2.7, for autoimmune disease and 2.0, CI 1.7 to 2.3, for immunosuppressive and immunomodulatory medications. Discussion. In a large national population, HSVE is strongly associated with pre-existing autoimmune disease and exposure to immunosuppressive and immunomodulatory medications. The role of antecedent immune-related dysregulation may have been underestimated to date. Next, we will be discussing articles in the field of pulmonary and critical care from New England Journal of Medicine. Early diagnosis and treatment of COPD and asthma, a randomized controlled trial. Background. Many persons with chronic obstructive pulmonary disease, COPD, or asthma have not received a diagnosis, so their respiratory symptoms remain largely untreated. Methods. We used a case-finding method to identify adults in the community with respiratory symptoms without diagnosed lung disease. Participants who were found to have undiagnosed COPD or asthma on spirometry were enrolled in a multi-center, randomized, controlled trial to determine whether early diagnosis and treatment reduces healthcare utilization for respiratory illness and improves health outcomes. Participants were assigned to receive the intervention, evaluation by a pulmonologist and an asthma COPD educator, who were instructed to initiate guideline-based care, or usual care, by their primary care practitioner. The primary outcome was the annualized rate of participant-initiated healthcare utilization for respiratory illness. Secondary outcomes included changes from baseline to 1 year in disease-specific quality of life, as assessed with the St. George Respiratory Questionnaire, SGRQ. Scores range from 0 to 100, with lower scores indicating better health status, symptom burden, as assessed with the COPD assessment test, CAT. Scores range from 0 to 40, with lower scores indicating better health status, and forced expiratory volume in 1 second, FEV1. Results. Of 38,353 persons interviewed, 595 were found to have undiagnosed COPD or asthma, and 508 underwent randomization. 253 were assigned to the intervention group, and 255 to the usual care group. The annualized rate of a primary outcome event was lower in the intervention group than in the usual care group, 0.53 versus 1.12 events per person year. Incidence rate ratio, 0.48. 95% confidence interval, CI, 0.36 to 0.63, p less than 0.001. At 12 months, the SGRQ score was lower than the baseline score by 10.2 points in the intervention group and by 6.8 points in the usual care group. Difference, minus 3.5 points, 95% CI, minus 6.0 to minus 0.9. And the CAT score was lower than the baseline score by 3.8 points and 2.6 points, respectively. Difference, minus 1.3 points, 95% CI, minus 2.4 to minus 0.1. The FEV1 increased by 119 milliliters in the intervention group and by 22 milliliters in the usual care group. Difference, 94 milliliters, 95% CI, 50 to 138. The incidence of adverse events was similar in the trial groups. Conclusions. In this trial, in which a strategy was used to identify adults in the community with undiagnosed asthma, or COPD, those who received pulmonologist-directed treatment had less subsequent healthcare utilization for respiratory illness than those who received usual care. From Journal of American Medical Association, dapagliflozin for critically ill patients with acute organ dysfunction, the Defender randomized clinical trial. Importance: sodium glucose cotransporter 2, SGLT, inhibitors improve outcomes in patients with type 2 diabetes, heart failure, and chronic kidney disease, but their effect on outcomes of critically ill patients with organ failure is unknown. Objective: to determine whether the addition of dapagliflozin, an SGLT2 inhibitor, to standard intensive care unit, ICU, care improves outcomes in a critically ill population with acute organ dysfunction. Design, setting, and participants: multi-center, randomized, open-label, clinical trial conducted at 22 ICUs in Brazil. Participants with unplanned ICU admission and presenting with at least one organ dysfunction, respiratory, cardiovascular, or kidney, were enrolled between November 22, 2022, and August 30, 2023, with follow-up through September 27, 2023. Intervention participants were randomized to 10 mg of dapagliflozin, intervention, N equals 248, plus standard care, or to standard care alone, control, N equals 259, for up to 14 days, or until ICU discharge, whichever occurred first. Main outcomes and measures. The primary outcome was a hierarchical composite of hospital mortality, initiation of kidney replacement therapy, and ICU length of stay through 28 days, analyzed using the win ratio method. Secondary outcomes included the individual components of the hierarchical outcome, duration of organ support-free days, ICU, and hospital stay, assessed using Bayesian regression models. Results among 507 randomized participants. Mean age, 63.9, SD, 15 years, 46.9%, women, 39.6% had an ICU admission due to suspected infection. The median time from ICU admission to randomization was 1 day, IQR, 0 to 1. The win ratio for dapagliflozin for the primary outcome was 1.01, 95% CI, 0.90 to 1.13, p equals 0.89. Among all secondary outcomes, the highest probability of benefit found was 0.90 for dapagliflozin regarding use of kidney replacement therapy among 27 patients. 10.9% in the dapagliflozin group versus 15.1% in the control group. Conclusion and relevance. The addition of dapagliflozin to standard care for critically ill patients and acute organ dysfunction did not improve clinical outcomes. However, confidence intervals were wide and could not exclude relevant benefits or harms for dapagliflozin. Next, we will be discussing articles from CHEST. National and Local Direct Medical Cost Burden of COPD in the United States from 2016 to 2019, and projections through 2029. Background. Despite the significant burden posed by COPD to healthcare systems, there is a lack of up-to-date information quantifying the general COPD burden, costs, and long-term projections to various stakeholders in the United States. Research question. What are the updated state-specific and nationwide estimates of the COPD disease burden and direct costs in 2019, along with projections of COPD attributable medical costs through 2029? Study design and methods. A cross-sectional, retrospective study design, using the 2016 to 2019 Medical Expenditure Panel Survey, 2019 American Community Survey, and 2019 Behavioral Risk Factor Surveillance System data, was applied to generate COPD attributable expenditure estimates. Cost projections for the years 2020 to 2029 were based on 2017 national population projections, reported by the U.S. Census Bureau, and all costs were adjusted to 2019 U.S. dollars. Results. In total, 4,135 people living with COPD were included. A higher proportion had other concurrent conditions, such as cardiovascular-related conditions, compared with people without COPD, N equals 86,021. Overall, in 2019, COPD attributable medical costs after adjusting for demographic characteristics and 19 concurrent conditions, including COPD-related and non-COPD-related conditions, were estimated at $31.3 billion, with state-specific cost estimates reporting wide variation, from $44.8 million in Alaska to $3.1 billion in Florida. Nationwide COPD attributable medical costs, borne by payer type, were as follows. Private insurance, $11.4 billion, Medicare, $10.8 billion, and Medicaid, $3.0 billion. Projections of national medical costs attributable to COPD are reported to increase to $60.5 billion in 2029. Interpretation. Understanding the current disease and economic burden of COPD in the United States, along with the projected costs attributable to COPD in the next decade, will highlight unmet needs and gaps in care that help inform healthcare decision-makers in planning future actions to alleviate this disease burden. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology. Protected time for program administration among nephrology program leadership in the United States. Background. In 2022, the Accreditation Council for Graduate Medical Education reduced minimum program director protected time for program administration from 10 to 8 hours/WK, with no core faculty requirement. We surveyed program leaders regarding the effect of these changes. Methods. This is an anonymous online survey of all U.S. adult nephrology program directors, March 2023, who forwarded core faculty/associate program director, APD, surveys. The questions included protected time in 2022 to 2023 and 2021 to 2022, whether it was sufficient, estimated time needed, and 2 validated single-item burnout measures, emotional exhaustion and depersonalization. The analysis was descriptive. Results. Program directors. Their response was 62%, 90-149, with geographic distribution/approved fellow positions similar to those nationally. Overall, protected time slightly increased from 2021 to 2022, largely in greater than 6 fellow programs, but 42%, 1331, of these were still not meeting minimum requirements. Only 37%, 3081, agreed that they had sufficient protected time. Those with less than or equal to 6 fellows, estimated needing 11 ± 4H/WK, 15 ± 4H/WK, with greater than 6 fellows. 25%, 2081, reported high levels of emotional exhaustion. Core faculty. 57 of 149 program directors, 38%, forwarded the link to 454 faculty. 94% of APDs, 4952, responded, reported 3 ± 3H/WK protected time. 42% had none, and estimated needing 6 ± 3H/WK, regardless of program size. 67 of 402 core faculty, 17%, responded, reported 2 ± 3H/WK, 50% had none, and estimated needing 5 ± 3H/WK, regardless of program size. Greater than or equal to 85% of APDs and core faculty precepted clinical rotations, gave lectures, evaluated fellows, mentored scholarly work, and participated in recruitment. The majority assisted in fellow remediation, 34%, 1544, of APDs and 21%, 1361, of core faculty reported high levels of emotional exhaustion. Conclusions. Program leaders estimated minimum necessary program administration times, on the basis of program size, that exceeded the Accreditation Council for Graduate Medical Education requirements. APDs/core faculty contributed substantially to non-clinical training. 34% of APDs and 25% of program directors had a high likelihood of burnout. Next, we will be discussing articles is from Kidney International Reports. Aversion to a high salt taste is disturbed in patients with CKD. Introduction. A reduced salt intake is a vital lifestyle modification in the management of hypertension. Initiatives aimed at decreasing the intake of salt are based on the preference by humans for a salt taste. Salt intake behavior appears to be affected by the balance between attraction to a low salt taste and aversion to a high salt taste. However, aversion to a high salt taste has not yet been quantitatively investigated in both healthy individuals and patients with chronic kidney disease, CKD. Methods. Assessments of gustatory and aversion thresholds for salt, bitter, sour, and sweet tastes were performed using a stimulant-impregnated test strip in healthy subjects and patients with CKD. Results. In a pilot taste test of 125 healthy subjects, the number of participants with an aversive reaction increased at higher salt concentrations. The threshold for normal taste perception was arbitrarily defined as 10% NaCl, with 47.2% of healthy subjects displaying an aversive reaction. In taste tests performed by 70 patients with CKD, 10% were unable to recognize a salt taste, even at the highest concentration, 20% NaCl, suggesting a significant impairment in taste perception in patients with CKD. Only 15.7% of patients with CKD exhibited a normal aversion to NaCl, whereas 78.6% showed the complete loss of aversion to salt. Conclusion. The present results confirmed the anticipated aversive response to a high salt taste in humans, and demonstrated its impairment in patients with CKD, implying that patients with CKD have reduced resistance to a high salt intake.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.